Our next speaker is Fadel Zeidan, and he is a terrific investigator here at UCSD and runs the Mindfulness Center. And his talk is Neurophysiological Mechanisms Supporting Mindfulness Meditation Induced Pain Relief.
Thank you, Dr. Mobley. And hello, colleagues and friends and fellow investigators. What a delightful day. Thank you so much, Hert, for inviting me. I am also delighted to be here, although a little confused considering I'm the my work's kind of the antithesis of engineering and these kind of technological advances. But here I am. And so today I'll be talking about mindfulness and how that impacts one of man's most salient and undeniable experiences, pain. And pain is a wonderful thing. In my world, I study pain to appreciate consciousness, and then of course there's a suffering component. Pain, as Dr. Sarma elegantly described, is a problem in our country, and that's because pain is constructed and modulated by a constellation of interactions between the sensory, the cognitive, the affective dimensions, and this really makes pain incredibly difficult to treat, and yes, it is a financial burden. Costs our country alone $635 billion a year in lost work productivity, medical treatment costs, and as you all know, we are in the midst of an opiate epidemic. We've seen a 450% exponential increase in opiate misuse, and that's because really we don't have a cure for chronic pain, and it's largely an American problem with the opiate epidemic, but that's because it's so complicated. And it's so much so that our own Centers for Disease Control have postulated new guidelines for how we treat pain, and of the most primary guideline is the utilization of non-opioidergic, ideally non-pharmacological pain therapies, because opiates don't do anything to chronic pain except make them worse. There's a couple of JAMA papers that are coming out that show that that opiate use actually exacerbates chronic pain over the long term. So this is why I'm particularly interested in the cognitive modulation of pain and mindfulness. And raise your hand if you've heard of mindfulness. Okay, good. That's good. All right. So mindfulness if you go from one lab to another lab, you're going to get, and ask them how to define mindfulness, you're going to get variant characterizations. But obviously my laboratory has the right definition, and that is awareness of sensory events without reaction. And we can cultivate this construct through the practice of mindfulness-based mental training. And I'll get into that in a bit. So why would we get into studying mindfulness in pain in the first place? Well, mindfulness is associated with enhancing positive mood, cognitive control, emotion regulation, acceptance-based coping strategies, which are also phenomenons that assuage the experience of pain. But we also have some insight from some contemplative Buddhists. This is an ancient Buddhist script about, 3,000 years old. It's called the Salata Sutta. It's transcribed as the dart or the arrow, and it says that when the uninstructed run-of-the-mill person, i.e. the non-meditator, is touched by a painful bodily feeling, he worries, he grieves, he laments, he weeps, and is distraught. It's if the man is pierced by two darts, a physical and a mental dart. And this is incredibly accurate with our current understanding of modern-day nociceptive physiology. We do have two aspects of pain, as Dr. Sarma said. There is an A delta fiber that is highly myelinated and fast-acting, and then there's the slower, throbbing, burning C fiber mediated nociceptive processing that's associated slower, and it's unmyelinated. In the cortex, we also have two disparate systems that process the first, second sensory versus affective dimensions of pain. So this was really cool to see that, this ancient scripture is actually constant and consistent with our current understanding of pain. It goes on to say, but in the case of a well-taught disciple, i.e. a non-meditator, when he is touched by a painful feeling, he will not be distraught. It's one kind of feeling he experiences, a bodily one, but not a mental one. It's as if the man is pierced by the first, but not second dart. And that's interesting too, because we do have some emerging data showing that long-term practitioners, contemplatives with extensive practice do require significantly higher level of noxious heat to report the same amount of pain as age-matched controls. And the data, the neuroimaging data that's arose from this work shows that these adept meditators, when they're explicitly told not to meditate in the scanner, in the presence of a frankly noxious stimulus, that brain regions that correspond to processing the sensory dimension of pain the thalamus particularly, highlighted in orange, is highly active. But brain regions that are associated with appraising or reacting to the said experience are deactivated, as shown in blue, which is largely the more prefrontal areas. And this is something we don't really see in brain imaging pain research. We always see the prefrontal cortex. So what's this showing? This is showing that these adept practitioners can decouple the first versus second dart, the sensory versus the affective reaction, which is pretty interesting. But who has time, right, to spend decades in a cave meditating, right? I don't, although I'd love to. And so what we've now done is looked at 8 weeks of meditation training. Mindfulness-based stress reduction has been found to be profoundly effective on chronic pain. And now we're starting to see more and more emerging data on this. But again, 8 weeks is a long time for practice as well, especially for a chronic pain patient who is more liable to take a pill, right, that could, end quote, work in 45 minutes or so. So for the last 15 years or so, we've been developing a brief mindfulness-based mental training paradigm. This is 4 days of training, 20 minutes each day. The practitioner is taught to sit in a straight posture, eyes closed, and to focus on the changing sensations of the breath as it arises. The individual is taught to continuously focus on the tingling sensations from the nose, following the breath with the mind's eye down the throat, the chest, the belly, and back up. And not if, but when the mind gets distracted, which it will over and over and over and over again. The individual is taught to acknowledge that discursive sensory event without further judgment or reaction, and to gently bring the attention back to the breath. And what we think is happening here is a 1-2 punch. First off, when you're focusing on an automatic and dynamic stimulus in a repetitive fashion, what that's doing is enhancing your ability to promote cognitive control, cognitive flexibility, the ability to sustain attention in the present moment. And further, the individual is teaching his or herself to regulate emotional reactions that arise in the moment-to-moment experience. And what we think that the brain is no different than any muscle. So for instance, we can do repetitions with a weight to work out our biceps. And a function of time, you do this over and over. Obviously, I'm not going to be exhibit A on this one. But if you continuously do this weight over and over, your muscle's going to get stronger and stronger and stronger. And if you stop working out, there will be muscular atrophy. But the same is true for the brain, for the mind. We can train the mind to be more flexible, to sustain attention in the present moment non-reactively. And so we're looking at mindfulness-based mental training as analogous to physical training. And we've seen an exponential increase in mindfulness-based research. This is the first paper published by John Kabat-Zinn in 1982, and right now in 2019, this figure is right around here, around 700-800 papers per year. And it's all over the place. Am I right, Roger? It's all over the place. You can't check out a Whole Foods without seeing somebody meditating on the cover of a magazine. Right? We're getting a little bit carried away, aren't we? LeBron's meditating courtside. We have Oprah meditating with her Oprah blanket. We have these images in our head of Vietnamese monks burning themselves alive without flinching. And of course, the zenith of all popular culture, Anderson Cooper is now meditating on TV. We do have this phenomenon called McMindfulness, and I feel like we might be getting carried away. We don't actually know what it is. Any new pain or any new health-promoting therapy, drug, must go through multiple phases of placebo-controlled trials, but why is mindfulness-based research not being held to the same rigor? So I have dedicated my career to torpedoing it by identifying and asking the question, is this all just a placebo response? Because mindfulness could be just an effect of beliefs, respiration rate. Chronic pain patients are largely lonely. Can spending time with a facilitator be health promoting? And of course, conditioning is a powerful analgesic response. So what we've done in my laboratory is develop this so-called sham mindfulness meditation intervention. This is where we lead people to think they're practicing mindfulness when in fact they're not. So they are first told they're randomized to the mindfulness intervention. And then they sit with a straight posture, eyes closed, and every 2 to 3 minutes we instruct them to take a deep breath as we sit here in mindfulness meditation. Every single aspect of the genuine intervention is matched in the sham intervention except the explicit instructions to focus on the changing sensations of the breath in a non-reactive fashion. Are we good? Just a simple nod would be okay. Am I speaking too fast? The coffee here is very strong. So let's see here. I just got an Adobe message. Okay, so I know sugar pills work. right? Placebo is incredibly powerful. So I actually do care mostly about mechanisms. I care about how these things work as opposed to if they work. So in our laboratory, we used the same procedures and methods largely across all of our studies, but we try to target different analgesic and active mechanisms. We use this very scary looking device, this noxious heat probe, and we put their legs on this custom-made probe holder. And we stimulate them at 10 seconds, 12 second plateaus at 49 degrees Celsius. It's about, 121 Fahrenheit. And it does not tickle. It's incredibly painful, but doesn't cause tissue or damage or burns. And we assess psychophysically their behavioral responses to the stimulus with a visual analog scale. Here, where 0 is no pain and 10 is the worst pain imaginable, the more red you see, the more in pain you're on, and on the back are the numbers. So we're particularly interested in pain intensity versus pain unpleasantness. And we give our participants an analogy. Imagine you're listening to the radio, or in our current political climate, you could think of a noxious stimulus. How loud that stimulus is pain intensity, and how much you don't like it or how much it bothers you is more pain unpleasantness. So I'm going to show you a video now of what procedures really look like in our laboratory. This Jackson's going to be on the left, and he's going to be meditating. On the right is going to be Andy, who's not meditating. On the bottom is going to be an illustration of the noxious heat stimulus. So let's see if this works. There's Jackson. He got dressed up to be on TV, and Susie presses the button. There you go. And then the stimulus goes off right there. And then so we'll look at heart rate variability, we'll antagonize endogenous opiates, of course we'll scan them with fMRI, we'll do all kinds of things to these people, but we do pay well. And then after this experience, we collect their pain ratings and try to correlate these objective physiological markers with their behavior, of course. And particularly what we've done in our laboratory is champion the use of arterial spin labeling, perfusion fMRI. And we just wrote a primer on this and why we find that this technique is just remarkably appropriate for studying meditative states. This is basically where you see, this is a meditating brain right here. Red corresponds to activation, blue is deactivation. So let's get straight to the results. So in response to this noxious heat, this is an MRI session after respective interventions. The first half, we stimulate them with noxious heat. We ask them to close their eyes, don't move, please don't meditate. And then in the second half of the scanning session, during noxious heat, we ask them to meditate. And then we collect pain ratings. And on average, in the control group, which listened to a book on tape for 4 days, we see an 18% increase in pain responses. On the y-axis is pain, on the x-axis are groups. And the mindfulness group was more effective at reducing pain than the sham mindfulness group. But I want you to pay attention to something very important here. You see this 24% reduction? That is profound. So Don Price, using the same visual analog scales, the same heat stimulation procedures as we use, found that 1 IV clinical dose of morphine reduces pain by 21%. And all the folks are doing here is they think that they're meditating, which they kind of are, right, but not mindfully, and they report pretty dramatic reductions in pain. Having said that, mindfulness is more effective. So that's cool. But what happens in the brain? As you can see here, we have primary somatotopographic activation of S1 to the leg. Okay, so this is the representation of the right leg where we stimulated them. And it's highly active during rest and noxious stimulation, but no longer detectable when folks are meditating, suggesting that at least one avenue for pain relief from mindfulness is attenuating ascending low-level afferent processing. And across 2 separate studies, 2 different samples, and even 2 scanners, our regression models found similar results. Okay, so we have replicated our findings. We have found that higher activation in the orbital frontal cortex, this is a very evolved brain region. In the context of iPhones, this is like the iOS 20, okay? It's right behind the eyeballs, and this brain region is associated with cognitive control, emotion regulation, and changing the contextual evaluation of our sensory environment. Across 2 separate studies, we've also seen that greater thalamic deactivation is predictive of mindfulness-based analgesia, which is also something very novel. And what we've proposed in 2011, and in every other paper we've published, is that mindfulness is potentially engaging a new pain modulatory pathway. And we propose that mindfulness meditation is engaging the orbitofrontal cortex to down-regulate the thalamus through glutamate to shut down the gate through the thalamic reticular nuclei, which are GABAergic, and then to reduce the elaboration of nociceptive processing throughout the brain. This is in part of Francis Crick's searchlight hypothesis, Rorschach, and there's some, as well as talked about this for tinnitus, and we have some new emerging optogenetic data showing that this pathway actually exists. And it's supposed to be mediated by changes in executive attention to suppress distractors to focus on the intended object. This is largely something we see in visual neuroscience as well as audition. So what could be the shift in executive attention here? Well, we think it's focusing on the breath. Attending to an interoceptive process in conjunction with a motor response like the breath is shutting down the gate of ascending nociceptive information, because all information, that everything from the body has to go through the thalamus except the sense of smell. It almost is like the gatekeeper, and as Patricia Churchland would say, the thalamus and the TRN control the contents of our consciousness. So what we did was we wrote a grant, we were lucky enough to get it, and we explicitly tested this by changing our fMRI technique to bold, and we threw in a region of interest seed during noxious stimulation, mindfulness versus rest, in the thalamus, contralateral to the stimulation site. And what did we find? These data are less than a month old. We're still analyzing them. I'm still QCing them. But it worked out just as we hypothesized. We found that the thalamus was connected more strongly with the dorsolateral prefrontal cortex, ventrolateral prefrontal cortex, extending into orbitofrontal cortex, suggesting that there is stronger connectivity between the prefrontal into the thalamus. We saw greater decoupling between the thalamus and S1 to the leg. And this predicted analgesia directly. And we also saw greater deconnectivity between the thalamus and the posterior cingulate cortex, one of the central nodes of the so-called default mode network related to mind wandering. I just ran another analysis the other day. I didn't have time to put it on a slide, but we put in the seed in the right orbitofrontal cortex, and in fact, we found, again, just as a confirmatory analysis, stronger connectivity with the thalamus, and that predicted analgesia. Now, this is correlational, it's not causal, we can't do optogenetics in humans, but it provides even further credence that mindfulness is engaging a new, novel pain modulatory pathway. So we conducted some other studies to kind of get a better appreciation of how this is working. What is the role of endogenous opiates in mindfulness-based analgesia? You name it: distraction, placebo, acupuncture, transcranial magnetic stimulation, expectations, hypnosis, prayer. All those techniques reliably reduce pain, but if you inject them with an opiate antagonist, naloxone, the analgesia is no longer preserved, demonstrating that those cognitive techniques engage the body's endogenous opioidergic system to reduce pain, largely through the periaqueductal gray matter activation, which then activates the dorsal horn of the spinal cord, which then releases a cascade of endogenous opiates to assuage and attenuate nociceptive processing. Across all of our studies, we've seen that mindfulness engages multiple brain regions to reduce pain, and specifically greater activation of the perigenual ACC, right anterior insula, orbitofrontal cortex, all predict analgesia. These brain regions have high concentrations of endogenous opioidergic receptors. So you would think, okay, mindfulness, of course, engages endogenous opiates to reduce pain. But we always see the PAG deactivate. And that's something we never see in any manipulation. PAG is always on, even during pain, because whenever you stub your toe or whatnot, your body releases opiates. So we were left with a conundrum, so we wrote a grant, and we found that mindfulness, when we administered the highest dose of intravenous naloxone existent in the literature, we compared mindfulness in response to saline, of course this is double-blind, versus naloxone. We found that mindfulness-based analgesia was still preserved when we blocked endogenous opiates, clearly demonstrating that, again, there's potential novel mechanism here. So as a follow-up, I was really interested in kind of dissecting which part of mindfulness is non-opioidergic, is opioidergically mediated. So we broke down mindfulness to slow rhythmic breathing, sham mindfulness meditation, and mindfulness meditation. So here we had mindfulness versus sham. This time it was a crossover double-blinded randomized design, and we trained folks to slow their breathing to this light. And so they came in for baseline testing, then they got randomized to their 4-day groups. In this session, they got naloxone or saline, and then the other session, they got naloxone or saline, whatever they didn't get in session 6. Does that make sense? Maybe a nod on that one? Okay, this is currently under review. All of our techniques reliably reduced respiration rate. Okay, slow breathing, mindfulness, and sham. And what we found, and again, same axis here, Y is percent change in pain, X is our groups. This is the first study to show that slow breathing-based analgesia is non-opioidergically mediated. Red is naloxone, blue is saline. We replicated our mindfulness-based findings. Again, mindfulness does not engage endogenous opiates to reduce pain. This is our third study showing this. The second study was published in Psychosomatic Medicine showing that adept meditators don't engage the body's opiate system. We thought after practice you might develop a placebo response. But what we found, remarkably, was that we knocked out sham mindfulness meditation-based analgesia with naloxone. So what's the component here? Is it slow breathing? I mean, this paper retracted my hairline even further than it is. I mean, it was pretty, I didn't understand what was going on here. I thought it was just slow breathing, but it's not. We dove into the qualitative data that we collected, and we coded it. And we found that 19 out of the 20 slow breathers, 20 out of the 20 mindfulness meditators said they focused on the breath doing their techniques. 6 out of the 20 sham meditators said they focused on the breath. So we ran a regression model and found, in fact, that attending to the breath was the part that was predicting non-opioidergic analgesia. So it's not this reappraisal, non-reactive piece that I thought was being engaged that's non-opioidergic for mindfulness. It was simply attending to the breath. And that is something that is remarkably easy to practice if you're a chronic pain patient. If you have fibromyalgia, chronic fatigue syndrome, CRPS, so on, you can have massive amounts of cognitive fatigue as a function of your disease. So practicing something as nebulous and like mindfulness can be difficult. But slow rhythmic breathing and attending to the breath in an interceptive fashion can actually be very health promoting and is potentially engaging this new pathway. So again, thank you so much for your attention and your invitation here. I'm happy to take any questions. This work's funded by the NIH and the Mind and Life Institute, and I'm relatively new here, so we are hiring postdocs, techs, so send me your people.
Thanks.
Thank you.
Appreciate it. Questions for Fadel?
Would you please define slow, fast breathing?
Sure. So the light was supposed to train people to breathe at 5.5 breaths per minute. Slow breathing, but it didn't. Our subjects were breathing about 14 breaths per minute, and they went down to about 9 across the board. So it wasn't at the sub-6 level, but we didn't want to introduce a distractor during the experiment, so we wanted them to self-regulate.
Wonder how much individual differences you have to account for. Athletic, would have a slower breathing compared with the normal.
So there were no significant pre- or post-intervention differences. Of course, there is variability, but I have to say most of our subjects were healthy. And the age range was 18 to 65, and the average age was 27.
Okay, thank you.
You're welcome, thanks.
So can you comment on actually, did you guys measure the depth of inhalation or expiration or the duration, the differences between breathing in and breathing out? And is there any relation to what you have been presenting?
It's a great question. We have those data. They need to be dissected. We only looked at rate for the sake of simplicity. But yes, I believe that would have an impact. Now, it's important to note that the mindfulness group was explicitly instructed not to change their breathing rate. But in order to focus on the breath, the person has to slow down their breathing. The other two groups especially the slow breathing group, was explicitly told to match their breathing rate to the light. But we did not introduce the light in the experiment after the intervention because distraction is opioidergically mediated and we wanted to avoid that. Long story short, we had the data, we haven't analyzed it. You're more than welcome to. Yes.
So I like to say that mind is for movement, right? Evolutionarily, creatures who have nervous systems are creatures who move through the world. And there's been some work on movement-based contemplative practices. And you can see also how it might, especially with the breath component, how it would help. But it's not just the breathing rate, it's the tending to the breath maybe. But I wanted to ask you if you are doing anything with movement-based mindfulness.
We are not.
Would you be interested in?
I would be interested. Are you speaking of Tai Chi or yoga or walking
Feldenkrais.
meditation?
Feldenkrais as well? Feldenkrais
Oh,
method,
right. Yes, I've heard of this.
Yeah.
Yes, of course I'm interested. Thank you.
In the back.
I wanted to ask, how long does the pain which you induce last? You know, like, is it a matter of seconds, minutes?
The pain goes away after the stimulus turns off.
Mm-hmm. So this is mostly acute pain.
Correct.
Yeah? Okay. And there are different mechanisms of acute and chronic pain.
Most definitely.
Yeah. So how do you see the transfer of these
Stay
findings
tuned.
to the?
We're running the projects now. We do think it's going to translate well. Our preliminary data, let me see if I have it. I do have it. Oops, I do have it, if you bear with me.
Mm-hmm.
So we have an N of 5. We just got an R01 to do this work. These are chronic low back pain patients, and they have radiculopathy. And yikes, I apologize. Let me get this. So they have radiculopathy, and what we did was we elicit their low back pain by lifting their legs up. It's called the straight leg raise test, and that induces the sciatic shooting pain down the leg. Are you with me? And what we found was that, let me see here. Mindfulness, after 3 training sessions, reduced pain intensity by 62%, after 8 sessions by 85%, and then on intensity and on the unpleasant side, it was 85%. After rest, after a 2-week follow-up, they reported a 70% reduction. Mind you, this was not placebo-controlled, so we have to do the work well. The 70% reduction was everyday life. Do you know what outcome was impacted the most, which I didn't predict at all? I didn't even measure it. Yes, sleep.
In addition to movement-related and breath-related meditation, there's these traditions where it involves visualization of something extremely colorful, dogen kinds of things. How much of this could be attributed just to focused attention on anything in particular?
I don't know that answer. I do think the breath is important. Because it's dynamic enough to change, to keep attention sustained, and increases flexibility. But in Zazen, in Zen meditation, practitioners just sit and stare at a wall. So I don't know.
It's not actually a question.
Okay.
I wish one day you will have time to study special group in Asia Minor, Anatolia, the cradle of the civilizations. There's a group of the folks, they come from Sufism. They are dervish, whirling dervish. They can dance almost like 24 hours and try to communicate with the God, although I'm not a very religious person. They are not religious either. But it could be a very interesting group of meditation group you need to focus on. And also those part of the world, people, they use the music for treatment in Pergama, which is 2,300 years ago. They were looking for the music treatment of the mental disease. And the Ottoman Empire time also, Adrianopolis, Edirne, they were also treating mental people with Sufism, same group of the folks they use for whirling dervishes.
Thank you. So I'm interested in this, and I'll tell you why. So throughout time, we have used, what do we call those beads, the roseberry beads? The
Rosary.
rosary beads and drumming, drumming and focusing on the breath in a rhythmic fashion and doing the twirls. What's happening? What's the constant between all those ancient practices that has survived till 2019? Rhythm. A repetitive rhythm. And there's something that we tap into when we can sustain the rhythm in that cyclical fashion. What that is, no clue. But I would imagine that Sufism and this beautiful spiraling, yes, is potentially tapping into that same mechanism.
So maybe we could conclude by saying if you don't have rhythm and you don't have music, at least you should take a deep breath.